Hello, my name is Van de Keyser. I am a neuroradiologist working in Ghent University Hospital in Belgium, and welcome to this video presentation on a quite complicated topic, anatomy of the brainstem with a focus on imaging. But I tried, as I usually do, I tried to make it really easy and hope to make it understandable. So what are going to be the topics of today? I'm going to start with a short introduction. Then there are going to be three short sections dedicated to specific brainstem functions, the functions that are vital to life, the fact that the brainstem connects all parts of the central nervous system, and the fact that most of the cranial nerve nuclei are located in the brainstem. And then I'm going to discuss the specific anatomy of the midbrain, the pons, and the medulla oblongata. So let's get started with a short introduction. What is the brainstem? I'm going to remove the video screen now so it doesn't interfere with the slides, despite the fact that people who are knowledgeable in marketing have advised me to always keep a video screen open because apparently that would attract more viewers. Maybe if I would look a little bit better, that would be true. I don't really believe it, so I'm going to close the screen. Okay, what's the brainstem? We all know it. It's a very small structure. It's the most inferior and also the most primitive part of the brain. It weighs only 2.6% of the total brain's weight, but nevertheless, it's extremely important, located at the center point between the cerebral cortex, the cerebellum, and the spinal cord, connecting all these parts of the central nervous system with one another. The brainstem can be brainstem anatomy and function can be made very simple by using the rules of three. The brainstem is composed of three parts: the midbrain, the pons, and the medulla oblongata. It consists of three layers, namely the basis, the tegmentum, and the tectum, and the functions can be grouped in three major categories. Let's start with the three parts of the brainstem. So as said, we have a midbrain, a pons, and a medulla oblongata, and this distinction is based on the gross anatomy. So we can see that these look a bit different anatomically, but also as an embryological basis. As you know, the embryological brain, consists of three vesicles, or it starts as three vesicles: the prosencephalon, or the forebrain, the mesencephalon, or the midbrain, and the rhombencephalon, or the hindbrain. And in a 5 to 6 week old embryo, we see that these vesicles, these three vesicles, have increased and turned into five vesicles. The prosencephalon has split into a telencephalon, which will become the cerebrum, and a diencephalon, which will give rise to the thalamus, hypothalamus, epithalamus, but also the optic nerves. The mesencephalon does not split in half. It remains the mesencephalon, or future midbrain, and we have the rhombencephalon that divides in the metencephalon, which will become the pons and the cerebellum, and the myelencephalon, which will turn into the medulla oblongata. So okay, that's an embryological explanation for the subdivision of the brainstem in three parts. And if we look at these axial slices, we see that these three parts also have a quite different shape. The midbrain looks a bit like Mickey Mouse because of the cerebral peduncles, which look a bit like big Mickey Mouse ears. The pons looks a bit like a giant belly, or a big fat belly. And then we have the medulla oblongata. You have to use your imagination a bit, but if you want, you can recognize a butterfly shape. So here we have them again on this slide. And when you really use your imagination, I believe you could also recognize a pair of boots in the medulla oblongata with the tips pointed outwards. And then we have a brainstem that looks a bit like a big fat Mickey Mouse wearing fuck me boots. Okay, so that's the division of the brainstem in three parts. How about the three layers? So we have a ventral layer in the brainstem called the basis. We have a more posterior layer called the tegmentum. And then we have a small tectum, which is only present at the level of the midbrain. The division of the brainstem in these three layers is based on embryology, so I'm going to discuss brainstem embryology a bit more in detail in the next slides, but also on the organization of the white and gray matter in the brainstem, and there's also a functional basis, so you will encounter different functions in these different layers. Let's start with some embryology. So here I'm going to illustrate the embryology of the spine, but keep in mind that it's a bit similar for the brainstem. It's just more easy to understand if I use the spine. So this is how the spine starts. So we have a central hole, the central canal, surrounded by an ependymal layer. Then we have the mantle layer, which will become gray matter or the future gray matter of the spinal cord, and it is surrounded by the marginal layer, which will become the future white matter. During embryological development, we see that anteriorly in the developing spinal cord, we get the development of motor nuclei. So we get motor functions in the so-called basal plate, so the ventral part of the developing spinal cord, and sensory nuclei develop posteriorly in the so-called alar plate of the developing spinal cord. So this is what the spinal cord eventually looks like, and we have sensory neurons located posteriorly in the dorsal horns and motor neurons located anteriorly in the ventral horns. And in the brainstem, this functional division is quite similar. If we look at these axial slices, the two-weighted slices, we have the basis of the brainstem located anteriorly, which is basically the equivalent of the embryological basal plate, and it contains the descending motor pathways, for instance, or the most important one being the corticospinal tract. Then we have the tegmentum. Notice that the tegmentum is quite extensive in the midbrain and the medulla oblongata, while the basis is more extensive in the big fat pons. And the tegmentum kind of correlates to the alar plate, and it contains the ascending sensory pathways and also the cranial nerve nuclei. And finally, we have the tectum, which is only found at the level of the midbrain, which contains nuclei for visual and auditory reflex processing. So the functions there have to do with basic visual and auditory reflexes. Okay, so I hope that made that clear. Then the functions of the brainstem, there are a lot of functions, but we can basically group them into three major categories. The first one would be what I call the stem of life functions. In the brainstem, we find a lot of nuclei which are necessary for survival, for the regulation of our heart rate, for instance, blood pressure, respiratory rate, and so on. And those are mainly found in the lower medulla oblongata. Then the brainstem is also the big connector. It connects all parts of the central nervous system to one another. It is traversed rather by a lot of white matter tracts which connect the cerebral cortex with the spinal cord, with the cerebellum, and so on. And finally, it houses the nuclei of most cranial nerves. Let's now discuss the functions of the brainstem in a bit more detail, and let's start with the stem of life functions. So when it comes to the stem of life functions, there are several nuclei in the brainstem which cannot be recognized on your conventional MRI images, but are nevertheless there, that are necessary for survival. We have a cardiac center, which is responsible for the regulation of our heart rate. We have three respiratory centers, two in the medulla oblongata and one in the pons, which regulate our respiration rate. We have a vasomotor center, which regulates blood pressure, and we have the area postrema, which is responsible for the regulation of hunger, thirst, which is the vomiting center of the brain, and several similar functions. And as you notice, most of these are, as said, found in the lower medulla oblongata. Also found in the brainstem is the so-called reticular formation. The reticular formation is not one specific structure, it's basically a complex network of interconnected neurons and nuclei extending all the way through the brainstem from the medulla oblongata to the midbrain, and it's located in the brainstem tegmentum. And The reticular formation is crucial for the regulation of arousal, consciousness, wakefulness, attention, and several autonomic functions. It has two components. We have an ascending reticular activating system, which projects to the thalamus and the cerebral cortex. It is vital for consciousness, wakefulness, alertness. It plays an important role in the sleep-wake cycle, and damage of this system will lead to coma or a vegetative state. We also have a descending reticular system, which projects to the spinal cord and is more involved in autonomic and motor functions like regulating posture, muscle tone, and reflexes. Let's move on to the role of the brainstem as the big connector. The brainstem contains a lot of extremely important white matter tracts, and that also means that I will have to talk about a little bit about those. So we can make a distinction between descending pathways, which are motor pathways, which go from the cerebral cortex to the spinal cord or the brainstem. We also have ascending sensory pathways carrying sensory information that needs to get to either the brainstem or the cerebral cortex, information coming or transmitted through the spine. And lastly, we have the cerebellar peduncles, which are basically three paired white matter tracts that connect the cerebellum reciprocally to the rest of the central nervous system. Let's illustrate the motor pathways. Maybe this is very basic for you, but you need to know what, for instance, the medial lemniscus is if you want to understand the rest of this presentation. So some basic neuroanatomy. Let's start with the motor pathways. In this presentation, I will often talk about the corticospinal tract, which is basically the primary motor tract of the central nervous system, carrying primary motor information from the primary motor cortex and the cerebral cortex to the spinal cord, and it runs through the brainstem and decussates at the level of the medulla oblongata. The corticobulbar tract is basically the same, but in this case, primary motor information is carried from the primary motor cortex to the motor nuclei of several cranial nerves located in the brainstem. And finally, we have the so-called corticopontine tract. What is that? Information is also carried from the primary motor cortex, but also from other cortical areas to the cerebellum. This is basically information about, let's say, intended motor movements. They are relayed to the cerebellum, and the cerebellum will, through other pathways, also receive sensory information. This way, the cerebellum can see if the intended movement correlates with the executed movement, and if not, try to correct it. So the corticopontine tract is part of a more extensive network. I'm going to talk more about that later. Now, just know that it is there. It's one of the motor pathways, and it goes from the cortex to the pons. And the pons, it synapses in the pontine nuclei, and then it is transmitted this information to the contralateral cerebellar hemisphere through the middle cerebellar peduncle. That will come later in more detail. Let's talk about the sensory pathways. There are three main ones you need to know for this presentation. We have the medial lemniscus, which carries sensory information about proprioception, fine touch, and vibration from the spinal cord to the cerebral cortex. There's a first synapse at the level of the medulla oblongata and a second one at the level of the thalamus. Then we have the spinothalamic tract. The spinothalamic tract carries information about crude touch, pain, and temperature. This information has already decussated low in the spinal cord, so there's no decussation at the level of medulla oblongata. There's a synapse at the level of the thalamus, and then this information is relayed to the cerebral cortex. And finally, we have the lateral lemniscus, which carries auditory information from the brainstem to the primary auditory cortex and the Heschel gyrus and the temporal lobe. Okay, so medial lemniscus, spinal thalamic tract, and lateral lemniscus. Where are those pathways located in the brainstem? I made these diagrams, took me a lot of work to illustrate them. So motor pathways are located in the bases. So in the midbrain, we will find motor pathways in the cerebral peduncles. Uh, Sensory pathways will be located in the lemnisci and the midbrain tegmentum. Let's analyze the motor pathways in a bit more detail. The corticospinal and bulbar tracts, so part of the pyramid system, are located basically centrally in the cerebral peduncle, and anteriorly and posteriorly of it we find, and the information there is also organized somatotopically, so face information is located more anteriorly or medially, followed by arm information, information about the trunk, and innervation to the leg. So then in front of it, we find frontopontine fibers, which are part of the cortico-pontocerebellar pathway. And at the back of it, we find the temporopontine fibers, also part of the cortico-pontocerebellar pathway. When it comes to sensory information, we find the lemnisci, so basically a combination of various sensory pathways, and the midbrain tegmentum. We have the medial lemniscus containing fine touch, vibration, and proprioception information. We have the trigeminal lemniscus containing sensory information from the face or carrying sensory information from the face. And finally, the spinal lemniscus, which is basically another word for the spinothalamic tract, carrying information about crude touch, temperature, and pain from the body to the cerebral cortex. At the level of the pons, the corticospinal tract is also, of course, located in the basis. We also find a lot of pontine nuclei and the basis of the pons, so a lot of gray matter nuclei, and these pontine nuclei is where the corticopontine fibers synapse and decussate, and then cross to the contralateral cerebellum through the middle cerebellar peduncles. You see these other small motor tracts. These are the corticobulbar tracts, carrying primary motor innervation to the motor nuclei of several cranial nerves, and we have the corticopontine tracts carrying information from the cerebral cortex to the pontine nuclei as said. Then we have the medial lemniscus and the spinothalamic tract, and we also find the lateral lemniscus at the back of the pons tegmentum. We also see the superior cerebellar peduncles, but I'm going to talk more about those later. And finally, the medulla oblongata, once again in the basis, which is quite small, we find the corticospinal tracts, and this here, it has a bit of a nodular appearance, is also called the pyramid. We also have the medial lemniscus located paramedially in the medulla oblongata, and more laterally, more posterolaterally, we find the spinothalamic tract. And then we have the inferior cerebellar peduncles located over here. Okay, let's also look at a pathological case, because pathology can sometimes be used to illustrate anatomy. This is a patient with a very extensive old infarction of the left cerebral hemisphere. This is an old infarction of the middle cerebral artery territory, as you can see. And if we look at the brainstem of this patient, we see that the cerebral peduncle is a lot smaller on the left side compared to the right side. This is due to Wallerian degeneration of the corticospinal, corticobulbar, and corticopontine fibers, which are, of course, the primary cortex is damaged over here, which have now degenerated, causing atrophy. We also see that at the level of the pons, we see that the left side of the pons is a bit smaller, so the belly is not as fleshy on the left side compared to the right side due to Wallerian degeneration, and we even see it at the level of the medulla oblongata, where the pyramid over here is extremely small and looks a bit flattened compared to the other side on this image over here. Okay, if we look at conventional T2-weighted images, like shown here, it's impossible to see the various white matter tracts that are present in the brainstem. We can, however, visualize those using diffusion tensor imaging. Then we can visualize the white matter tracts using these color maps, and the corticospinal tracts are located over here in the basis of the pons, and at the back in the tegmentum we find the medial lemniscus and other sensory pathways. This allows us to infer whereabout we could expect a corticospinal tract on an axial T2 aided image, so about here in the base of the pons, and the lemnisci should be located about here, somewhere over here in the tegmentum. We also see these red fibers over here. These are the pontocerebellar fibers. As said, the corticopontine fibers synapse in the pontine nuclei, and then these other axons cross to the other side via the pontocerebellar fibers, and they run all the way to the contralateral cerebellar hemisphere through the middle cerebellar peduncles. So this brings us to the cerebellar peduncles to finalize our discussion on the white matter tracts in the brainstem. So the cerebellar peduncles are basically a group of 3 paired white matter tracts connecting cerebellum with the rest of the central nervous system. We have, here we see fibers coming from the cerebral cortex. These are corticopontine fibers, and as said, these will synapse in the pontine nuclei located in the basis, and pontocerebellar fibers will cross through the middle cerebellar peduncles to the contralateral cerebellar hemisphere. So what do the middle cerebellar peduncles do? These are basically the major input highway to the cerebellum. So information from the cerebral cortex is carried into the cerebellum across the middle cerebellar peduncles. Then we also have another highway, a bit smaller, the inferior cerebellar peduncles. This is basically motor information. This is sensory information coming from the spine. And this sensory information is relayed from the spine into the cerebellum through the inferior cerebellar peduncles. Then we also have an output system, the superior cerebellar peduncles. So we have motor information entering the cerebellum through the middle cerebellar peduncles, sensory information from the spine through the inferior cerebellar peduncles, and then we have information leaving the cerebellum back to the cerebral cortex and also to the thalamus and then to the cerebral cortex through the superior cerebellar peduncles. Okay, I hope that's clear, but I always like to repeat myself because repetitia est mater studiorum, as they say in Latin. I don't really speak Latin, but I know that phrase. So repetition is the mother of all study. So we have the middle cerebellar peduncle carrying motor information, well, more than motor, but let's use motor information for the sake of simplicity, from the primary motor cortex to the cerebellar cortex. And basically, this is information about planned motor movements. Then we have sensory information coming from the spine through the dorsal columns, but also a bit from the vestibular nuclei. And based on the incoming motor information and the incoming sensory information, the cerebellum can see if the planned movement corresponds with the executed movement. And if not, it can try to correct it. The information about whether or not the movement is correct is relayed back to the cerebral cortex through the superior cerebellar peduncle. So this information mainly comes from the cerebellar nuclei, mainly the dentate nucleus, and is carried to the thalamus and the cerebral cortex. Okay, and this combination of the corticopontine system, and this is called the dentato-rubrothalamic tract, but you can forget that again. It's called the cerebello-cerebral loop. Okay, now let's illustrate the cerebellar peduncles on imaging. This here is an image performed at the level rather of the upper pons, and we see these two small structures here. These are the superior cerebellar peduncles, and notice that they slope downward postero-inferiorly. Then, at the level of the lower pons, we can see these very large white matter tracts. These are the middle cerebellar peduncles. And finally, at the level of the pontomedullary junction and also at the level of the medulla oblongata, we can infer the location of the inferior cerebellar peduncles. They are more difficult to recognize. They should be located posterolaterally at the level of the medulla oblongata, and then they extend a bit along the back of the fourth ventricle. So they should be located about over here approximately, but we can't really distinguish them on our conventional T2-weighted images. Okay, final function of the brainstem. They house, or the brainstem houses, the nuclei of most cranial nerves. Exceptions are the optic nerve, the olfactory nerve, and the spinal accessory nucleus. So the accessory nerve has information coming from the brainstem, but most of it comes from a spinal nucleus. Now, when it comes to the location of the cranial nerves, we can use the rule of 4, meaning that the first 4 cranial nerves are located at the level of the midbrain or above. As said, the optic nerve and olfactory nerve do not come from the brainstem or do not enter the brainstem. So what do we find at the level of the midbrain? The 3rd and 4th cranial nerve. Then we have the 5th through 8th cranial nerves located at the level of the pons, and at the level of the medulla oblongata we find the 9th through 12th cranial nerve. Let's talk a bit more about the cranial nerves in detail. Let's start once again with a little bit of embryology, because embryology sometimes helps us to understand anatomy. We have discussed the embryological development of the spinal cord, and we said, well, for the brainstem, it's a bit similar. Well, not exactly, but it helps us to understand it. What's the difference? For instance, in the brainstem, we have the development of the fourth ventricle, and this changes brainstem anatomy a bit because the developing fourth ventricle pushes the alar plates more laterally. So the alar plates are located more laterally rather than posteriorly compared to the spinal cord and the brainstem. This means that the motor cranial nerve nuclei will be located medially in the brainstem, and the sensory cranial nerve nuclei will be located laterally in the brainstem. On this slide over here, this is basically a summary of all cranial nerve nuclei. This is a bit theoretical, so try to stay with me. If you don't know a lot about neuroanatomy, I think it's probably an important slide, despite the fact that it is or looks a bit boring. So we can divide the cranial nerve nuclei in motor nuclei and sensory nuclei, but we can also make a further distinction between several types of motor nuclei and several types of sensory nuclei. When it comes to motor nuclei, let's start with the somatic motor nuclei. What are the somatic motor nuclei? Those are basically the motor nuclei that will innervate structures that are embryologically derived from somites. What are those? Those are nuclei like the oculomotor nucleus, innervating most of the extraocular muscles, with the exception of the inferior oblique muscle, which is innervated by the trochlear nerve. And then at the level of the pons, we find the abducens nerve, which will innervate the lateral rectus muscle. Finally, we have at the level of the medulla oblongata the hypoglossus nucleus, or the nucleus of the hypoglossal nerve, which innervates the intrinsic and extrinsic tongue muscles. The spinal accessory nucleus is a bit contentious. There are some who say it's not a somatic motor nucleus. It's not really important for this presentation. It's basically a motor nucleus that will innervate the sternocleidoid and trapezius muscle. Then we have brachial motor nuclei. What are those? Those are cranial nerve nuclei that will motorically innervate structures that are derived from how do you say it in English? From the branchial apparatus. So basically the face and the throat and so on, which have a different embryological origin. And belonging to those are the trigeminal motor nucleus. So the trigeminal nerve also has a motor component responsible for the innervation of the muscles of mastication. And of course also the facial nerve, which will innervate all the remaining facial muscles. Then we have the ambiguous nucleus, a nucleus that innervates both the glossopharyngeal and vagus nerves, and the ambiguous nucleus is basically responsible for the motor innervation of the muscles of the throat, of the pharynx and the larynx. And most of those are innervated by the vagus nerve. The glossopharyngeal nerve only innervates the stylopharyngeus muscle. Finally, we have visceral motor functions. Visceral motor functions are basically motor functions that belong to the autonomic nervous system. And belonging to those are the Edinger-Westphal nucleus, which is correlated with the oculomotor nerve. And it's basically the structure responsible for instance, pupillary constriction and lens accommodation. We also have the inferior salivatory nucleus, which is responsible for the parasympathetic innervation of the sublingual and submandibular glands and the lacrimal glands, and the superior salivatory nucleus responsible for the innervation of the parotid glands. And this almost brings us to the sensory system, but let's not forget the dorsal vagal nucleus, which is a quite important one because this is the motor nucleus responsible for the autonomic information of the thoracoabdominal viscera. There's a reason they call the vagus nerve the wandering nerve, because it extends all the way into the abdomen. So it basically crosses a big part of our body. This brings us to the sensory nuclei. So a very important one is the nucleus of the solitary tract, and it contributes to the facial nerve, glossopharyngeal nerve, and vagus nerve. It has various functions, but it's basically the sensory autonomic command center in the brainstem, to put it quite easily. So what kind of information does it receive? For instance, it plays a role in regulating blood pressure and respiratory rate because it receives information from baroreceptors, so receptors that are sensitive to changes in pressure, more specifically blood pressure, located in the carotids or in the aortic arch. It also receives information from chemoreceptors located in the carotid bodies and aortic arch. So these chemoreceptors will detect changes in the acidic level, the pH, I don't know if you say that in English, of the blood, or the CO2 level of the blood. And based on that information, respiratory rate can change. Taste is also a function of the nucleus of the solitary tract. So the facial nerve is responsible for the taste sensation in the ventral two-thirds of the tongue, and the glossopharyngeal nerve in the posterior third of the tongue. Vagus also plays a little role in taste sensation at the level of the epiglottis. And there are other functions, but these are, I believe, some of the most important ones. Now, then we have the somatic sensory nuclei, and these all belong to the trigeminal nerve, but has components in the midbrain, the pons, and the medulla oblongata. Let's start with the trigeminal sensory mesencephalic nucleus, which basically receives proprioceptive information coming from the muscles of mastication and the temporomandibular joint. Then we have the trigeminal principal sensory nucleus, which receives information about proprioception, vibration, and fine touch coming from the face. And finally, the trigeminal sensory spinal nucleus, which carries sensory information about pain, temperature, and crude touch coming from the face. And finally, we have the vestibulocochlear nuclei, which receive sensory information from the vestibular nerve, so about balance, and from the cochlea, so basically about hearing. Okay, a long slide, maybe a boring slide, but I think we need this information to carry on with our discussion of brainstem anatomy. Let's now localize these brainstem nuclei in the various parts of the brainstem. Let's start at the level of the midbrain. The two most important cranial nerve nuclei are motor nuclei, namely the oculomotor nucleus and the trochlear nucleus. The trochlear nucleus is located in the lower midbrain and the oculomotor nucleus in the upper midbrain. Associated with the oculomotor nucleus is the Edinger-Westphal nucleus, as discussed in the previous slide. Also found in the midbrain is the mesencephalic trigeminal nucleus, which, as said, receives sensory information about proprioception from the muscles of mastication and temporomandibular joint and belongs to the fifth cranial nerve. At the pons, at the upper pons, we mainly find trigeminal nuclei. We have the principal sensory nucleus of the trigeminus. We also have the trigeminal spinal nucleus. So basically, the spinal nucleus corresponds a bit to the spinothalamic tract of the face, and the principal sensory nucleus to the dorsal columns of the face. And we also have a motor nucleus, the trigeminal motor nucleus, responsible for the innervation of the muscles of mastication. The abducens nucleus is responsible for the innervation of the lateral rectus muscle, and here is the nucleus of the facial nerve. Then also found in the lower pons are the vestibular nuclei and the cochlear nuclei, not visible on this slide, and we still have the trigeminal spinal nucleus because that's a very extensive nucleus extending all the way to the upper spinal cord. Finally, we have arrived at the level of the medulla oblongata. Here we find the motor nucleus of the hypoglossal nerve located paramedially, where we find all somatic motor nuclei in the brainstem. We have the ambiguous nucleus responsible for motor innervation of the throat, the pharynx, and the larynx. We have the dorsal motor vagal nucleus responsible for the parasympathetic innervation of the thoracoabdominal organs. The solitary tract nucleus, an important sensory nucleus extensively discussed already. Once again, the spinal trigeminal nucleus, we find this guy everywhere in the brainstem, it seems, except the midbrain. And finally, the inferior vestibular nucleus. Okay, I hope this was not too theoretical for you. Let's now dive a bit more into brainstem anatomy on images. So we've already seen these slides. This is what the upper midbrain looks like and the lower midbrain on axial T2 weighted images. And quite clearly, it's not really possible to see all these internal structures on conventional images. So in a lot of cases, their presence there has to be inferred based on what we know about anatomy. We've already seen this slide with motor functions located in the basis and sensory functions located in the tegmentum. We have seen the anatomy of the cranial nerves already. What is new, or what are structures I haven't discussed with you already? Some extrapyramidal nuclei are also present in the midbrain, more specifically the substantia nigra located over here, and the red nucleus, and also the superior colliculi. So I talked about the tectum. It has two components. The upper component is called the superior colliculi, responsible for visual reflexes, and we have one cranial nerve exiting the midbrain at the level of the interpeduncular cistern, and that's the oculomotor nerve. And the lower midbrain, it looks a bit similar, so this is all the same. What are some differences? We also find, so cranial nerves is also the same. Extrapyramidal nuclei is basically the same. Nucleus ruber can no longer be seen here. So what's different? We now see a lateral lemniscus over here, which carries auditory information to the inferior colliculi. And the inferior colliculi are responsible for auditory reflexes. So these nuclei are basically responsible for the fact that if you hear a sudden loud noise, you instinctively turn your head towards the origin of the sound. And that's also what the superior colliculi do, but then for when something visual happens. So if you see something unexpected happening in the periphery of your visual field, you will automatically, without thinking, turn your head towards it to be able to see what's going on. This is a function that is happening at the level of the superior colliculi. We have one cranial nerve exiting the midbrain at the level of the lower midbrain, and that's the trochlear nerve, which exits at the back. So I'm going to illustrate it on images now. So this is the basis, this is the tegmentum, this is the tectum. We have already seen that. And this is what the midbrain looks like on conventional T1 weighted images, T2 weighted images, and susceptibility weighted images. And as already said, despite this very richness in anatomy, in this very small structure, we can only make up very little on conventional images. Basically, we see most on susceptibility weighted images. We can clearly see the extrapyramidal nuclei of the Substantia nigra and the red nucleus because, due to iron deposition, these have a lower signal. So let's look at a bit more detail. So this is the red nucleus, part of the extrapyramidal system, and this is the substantia nigra, also part of the extrapyramidal system. The substantia nigra basically is the ventral border of the tegmentum, which means that the structure located behind it has to be the midbrain base containing the corticospinal tracts. This is the midbrain base, so it has to be located over here. And based on what we know from anatomy, we know that the corticospinal and corticobulbar tracts have to be located somewhere in the middle of the cerebral peduncles. And then we know that they are that the information is somatotopically organized, with face coming first, then arm information or arm innervation, and then leg. And then located in front and behind the corticospinal and corticobulbar tracts, we find the frontopontine and temporopontine fibers of the corticopontine tracts. Okay, let's now move on to another example, but we've already seen it. We see that the cerebral peduncle on the right is a lot smaller than on the left. This is due to Ehlerian degeneration because this patient had an old right-sided middle cerebral artery infarction. This is a comparison of an axial T2 weighted image with one of the drawings I made of the midbrain. And well, we can make up the substantia nigra a little bit. We can see the red nucleus because they are more hypointense, and that's almost it. We can also see the rim of white matter surrounding the cerebral aqueduct. Haven't talked about it yet. This is the periaqueductal gray matter, and this plays a role in descending pain modulation. So these are white matter tracts going downwards, play a role in modulating pain information. Okay, so these we can distinguish, but for instance, the cranial nerve nuclei of the oculomotor and trochlear nerve, we can't really see them on your conventional MRI images. We just have to infer that they're located about there. We can, however, see them, or knowing where they are situated about is important when confronted with pathology. This is a diffusion weighted image in a patient with a left oculomotor palsy. And what do we see? We see that this patient clearly has an acute lacunar infarction located paracentrally in the left half of the midbrain in front of the cerebral aqueduct. Now, this is the upper midbrain, so this is where we know that the oculomotor nucleus is roughly situated. So the location of this infarction explains the clinical symptoms of this patient perfectly. This patient had a right oculomotor palsy. We once again see an acute ischemic infarction, hyperintense on diffusion weighted images, and black on the ADC map. This infarction, however, is not located at the level of the nucleus, which should be about here in front of the cerebral aqueduct, but of course the fibers of the oculomotor nucleus have to cross the midbrain tegmentum to exit the midbrain at the level of the interpeduncular cistern, and this infarction is no doubt located at a place where oculomotor fibers are running through the midbrain tegmentum, causing a right oculomotor palsy, despite the fact that the nucleus does not seem to be involved. On this axial T1 weighted image, almost all of the midbrain looks rather wide. Only around the cerebral aqueduct we see a slight difference, and this is the periaqueductal gray matter asset responsible for descending pain modulation. And located at the back of it, we see the tectal plate, which plays a role in auditory and visual reflexes. Periaqueductal gray matter can be involved in, for instance, Wernicke encephalopathy. Wernicke encephalopathy is, as you know, a toxic metabolic disorder caused by a vitamin deficiency, a thiamine deficiency, vitamin B1, and it's typically seen in alcoholics who then present with acute confusion, ataxia, nystagmus, as the main symptoms, and these patients typically have areas of edema medially in the thalamus and hypothalamus, as we can see here, and when the brainstem is involved, these abnormalities are typically located at the region of the periaqueductal gray matter, as we can see especially on these two upper images through the midbrain. This is already the level of the pons here, as you can see, but we also have signal abnormalities over there. So this was a case of Wernicke encephalopathy. So this is the tectal plate. So if we go a little bit of midline, we see the two components. So the tectal plate consists of four small, let's call them nodules. We have two located superiorly, called the superior colliculi, and two located inferiorly, called the inferior colliculi. And these are the superior colliculi on an axial image, and these here are the inferior colliculi. So you have to correlate with your sagittal images to know what you're looking at exactly. This is a coronal image, and we can see why in my own language we call those the four hill plate, and you can see why, because you have these four hill-like structures over here. Located above the tectal plate, we find the pineal gland, a very small structure, but in patients with a tumor that can compress the tectal plate and cause Parinaud syndrome. The tectal plate, as said, so I'm starting to repeat myself if I haven't done so several times already, but I do it a lot apparently. I'm going to repeat it now. I repeat myself a lot. They play a role in visual reflexes, and the inferior colliculi play a role in auditory reflexes, basically responsible for turning your head and your body towards a sudden visual stimulus or sudden auditory stimulus. And information is relayed from the tectal plate to the spinal cord through the tectospinal tract. Okay, I already told you about the Parinaud syndrome. This is an example. This is a very large pineal gland tumor compressing the tectal plate. This causes Parinaud syndrome in a lot of cases. And what is Parinaud syndrome? It's basically vertical gaze palsy. Patients with Parinaud syndrome cannot look up when asked to do so. And this is due to compression of several pathways responsible for vertical gaze. So for vertical gaze, several eye muscles have to work together. They rely on several pathways which are located in the dorsal upper midbrain, and these are compressed by the pineal gland tumor. So it's not really compression of the tectal plate, but rather of other pathways located in the vicinity. Okay, let's now illustrate the cranial nerves exiting the midbrain on high-resolution T2 weighted images. Over here, we see the oculomotor nerves exiting the upper midbrain and the interpeduncular cistern, the trochlear nerve is coming next, but now first here is the nucleus, or the presumed location of the oculomotor nucleus in front of the cerebral aqueduct, and here we have the fibers running to the midbrain tegmentum. This is the trochlear nerve, often difficult to see, so I was lucky to be able to visualize it in this patient over here. And the nucleus of the right trochlear nerve is located in the left side of the lower midbrain. So trochlear information crosses. So it's one of the few cranial nerves, if not the only one, where information actually crosses to the other side. So the trochlear nerve exits the lower midbrain dorsally at the level of the superior medullary velum, located over here, and then goes through the quadrigeminal cistern to the ambient cistern, and further on to the cavernous sinus. When it comes to pathology, well, when it comes to cranial nerves, the main thing is schwannoma. So here we see a small nodule located along the course of the oculomotor nerve. It is enhancing, as you can see on this image. So this is the normal oculomotor nerve. So this is a oculomotor schwannoma. I'm only showing this to illustrate the oculomotor nerve anatomy. Okay, let's now talk about the anatomy of the pons in a bit more detail. So we have an upper pons and a lower pons. So the structures we can find there are a bit different. So let's repeat these very quickly. So we have the corticospinal tracts in the base, as well as the pontine nuclei in the base. We also have corticobulbar and corticopontine tracts in the base. Then in the tegmentum, we find sensory information in the medial lemniscus and the spinal thalamic tract, and also in the lateral lemniscus. In the upper pons, we find several trigeminal nuclei, and we also find, as we can see here, and we also see the superior cerebellar peduncles over here. This is the medial longitudinal fasciculus, which is a white matter tract connecting the oculomotor nerve with the abducens nerve, and we will see later on that this white matter tract is very important for the horizontal gaze, but more about that later. So this is the lower pons, so we already know now where the corticospinal tract, medial lemniscus, and spinal thalamic tract are. We find, and here we have the pontine nuclei, medial longitudinal fasciculus. When it comes to cranial nerves, very important, in the lower pons we find the nuclei for the facial nerve and the abducens nerve, very important. We also find nuclei of the trigeminal nerve, the spinal trigeminal nucleus, and we find the vestibular nuclei over there, and also the cochlear nuclei, but haven't drawn them on this image. And we have the superior and middle cerebellar peduncles. Okay, let's now look at images. Once again, if we just look at an axial T2 weighted image, there's little we can really recognize from all these white matter tracts and nuclei, but we will be able to recognize more than you'd expect. So in the basis, we have the descending motor pathways, and the tegmentum, we find the cranial nerve nuclei and the sensory pathways. Let's start with that. So what can we recognize on axial T2 weighted images or axial T1 weighted images? Well, clearly the superior cerebellar peduncles are very easy to detect and recognize. Also the trigeminal nerve, which exits the pons at about halfway. The pons exits it, is the thickest cranial nerve, so very easy to recognize, and then enters Meckel's cave, where we find the Gasser ganglion, as you know. We can also recognize the middle cerebellar peduncles without much difficulty, as well as the facial colliculus and the vestibulocochlear and facial nerve, which we can see over here. And here we have the cochlea and the vestibulum and semicircular canals. Hey, what's that facial colliculus? You dropped the name and you didn't explain it. Well, let me try and do that now. So the facial colliculus is basically this very small, how should I call it? It looks a bit like a bottom over here. So it's basically the half of what looks a bit like a bottom. And what is causing this appearance, this facial colliculus? Well, we have on the one hand over here the nucleus of the abducens nerve, We have the facial nucleus also located in the lower pons at this level. That's not causing this protrusion or whatever you want to call it, no, but the nerves or the tracts or the fibers of the facial nucleus, they make a loop around the abducens nucleus to then exit the pons at the level of, well, the exit point of the facial nerve. And this loop, along with the abducens nucleus, is what causes the facial colliculus appearance over here. These are high-resolution T2-weighted images. We use those to examine the cranial nerves, for instance, when we need a lot of contrast between very small structures and cerebrospinal fluid. The vestibulocochlear nerve is very easy to recognize. We can even see it on thick slice T2-weighted images. Here we have the facial nerve located above the cochlear nerve over here. The trigeminal nerve is also very easy to recognize, but there's one nerve I haven't shown you which also exits the pons, and that's the abducens nerve. So over here we have the facial colliculus. Here we have the nucleus of the abducens nerve, and here we see the abducens nerve exiting the pons. The abducens nerve exits the pons very low, so it exits the pons in the lower pons, basically at the level of the pontomedullary junction, and then runs upwards towards the clivus. And it will enter the clivus in a very small canal named Dorello's canal. And we see here one of the right abducens nerve surrounded by a bit of CSF protruding into the clivus. The fact that the abducens nerve courses slightly through the clivus before entering the cavernous sinus always makes me examine the clivus very carefully in patients with an abducens palsy, especially oncological patients, especially elderly patients, are at risk for having a metastasis. And it wouldn't be the first time that I discover a bony metastasis in the clivus causing an abducens palsy in an oncological patient or an elderly patient. On these high-resolution sagittal T2-weighted images, we also see the abducens nerve. It exits the brainstem at the level of the pontomedullary junction and, as we can see on these consecutive slices, runs upwards and enters the clivus at the level of Dorello's canal or into Dorello's canal. And now that we are able to recognize the abducens nerve on thin sliced T2-weighted images, well, we know where it's located, we can actually often see it on thick sliced T2-weighted images as well. You just need to know where to look, and you know that now. So good luck finding it, and I'm pretty sure you will if you examine your images. Let's now illustrate the anatomy of the pons a bit more by using pathological cases, because pathology can be used to illustrate anatomy. What's wrong in this patient? Maybe at the first glance you'd say, well, nothing is wrong. Something is wrong. Look at the position of the eyes. Patient is squinting a bit. Clinical information, bilateral abducens palsy. That's all we knew. Patient was a refugee from Afghanistan. We had no medical records. We knew nothing about it. Communication was difficult due to the language barrier. So an MRI was performed, and this is what we see. Do you see anything out of the ordinary? Let's look at the pons. What's wrong? What's missing? Let's compare with a normal patient. The facial colliculus is not there. This is the place where we'd expect to find the abducens nucleus. Does that mean the abducens nucleus is missing? In this case, it was. This patient also had a very severe scoliosis. We Googled bilateral abducens palsy, scoliosis, no facial colliculus, and we found this. Horizontal gaze palsy with progressive scoliosis. It's a genetic disorder caused by a mutation in the ROBO3 gene. Was proven in our patient. We deliberately sought for the mutation. It was present. So this was a very rare case where the radiological findings led to a very specific genetic diagnosis. And what led to the diagnosis was absence of the facial colliculus. It's very easy to miss if you don't know that you have to see it as part of your normal brainstem anatomy. This is another patient who has a similar appearance but another syndrome. This patient also has no facial colliculus. What does this patient have? Well, clinically, the patient had a congenital bilateral facial palsy. This is a so-called Mobius syndrome. Mobius syndrome is not genetic, or as far as I know, there are no specific genetic mutations associated with it. The etiology is a bit unclear, probably multifactorial, and the most accepted theories is that it's caused by some kind of insult during embryological development interfering with the development of the facial nucleus. So these patients have no or a hypoplastic facial nucleus and often a hypoplastic or absent facial nerve, but we can't see that on these TIC-T2-weighted images, and are born with a congenital facial palsy. So it looks a bit the same as in the patient with horizontal gaze palsy with progressive scoliosis, but they had different clinical symptoms, but the appearance was a bit similar. This is a patient with a very small infarction. This infarction is located at the level of the upper pons. How do I know? Because I can see the cerebellar peduncles. If I can see the cerebellar peduncles, I know I am looking at the upper pons. The patient had diplopia, but in the upper pons we don't find oculomotor cranial nerve nuclei. So the abducens nucleus is located in the lower pons. What's causing the diplopia if it's not an insult in a specific cranial nerve nucleus? Well, this patient had what we call internuclear ophthalmoplegia. It is caused by a lesion between cranial nerve nuclei, more specifically in a white matter tract called the medial longitudinal fasciculus. What does the medial longitudinal fasciculus do exactly, and what is internuclear ophthalmoplegia? Let me explain. Internuclear ophthalmoplegia, and I'm going to make it very easy. What happens if you look to the right? Okay, if you look to the right, both your eyes need to move to the right, but this involves different muscles. In the case of your right eye, you need to activate your lateral rectus muscle, which is innervated by the abducens nerve. In case of your left eye, you need to activate your medial rectus muscle, which is innervated by the oculomotor nerve. These two nerves have to work together if you want to have a simultaneous movement of both eyes to the right. How does that happen? Well, it all starts in the brain at the level of the frontal eye fields, which are located posteriorly in the middle frontal gyrus. These activate a structure in the brainstem contralaterally called the pontine paramedian reticular formation, and this in turn activates the abducens nucleus. The abducens nucleus, in this case located in the right part of the brainstem, will innervate the lateral rectus muscle of the right eye, causing the eye to be pulled outward or to abduct. Okay, but now the left eye, how does that happen? Well, the abducens nucleus also activates the contralateral oculomotor nucleus through a white matter tract called the medial longitudinal fasciculus. And this medial longitudinal fasciculus decussates quite rapidly. So it is located, when it comes to moving your eyes to the right, we need the left medial longitudinal fasciculus. Okay, now the contralateral oculomotor nucleus is activated and the left eye will adduct or be pulled inwards, and the result is we are looking to the right. What happens if you have an insult in the medial longitudinal fasciculus? Then you get internuclear ophthalmoplegia. What is that exactly? Well, let's look at what happens. Imagine you have an insult in the left medial longitudinal fasciculus. If you want to look to the right, the left part of the brain will stimulate the right abducens nucleus, and your right eye will abduct. It will be pulled outward. So far, so good. But you cannot activate, because the left medial longitudinal fasciculus is damaged, you cannot activate the left oculomotor nucleus. So nothing happens in the left eye. It will stand still. And the right eye gets confused because you get like diplopia because your other eye doesn't move, and it will start to show nystagmus. And that's internuclear ophthalmoplegia. So if you want to look to, let's say, the right side, then your right eye will correctly abduct, but your left eye will do nothing. It is paralyzed. And your right eye will abduct, but will also have nystagmus. If both medial longitudinal fasciculi are damaged, you get what is called wall-eyed internuclear ophthalmoplegia, and in rest, both eyes are deviated towards the lateral sides. Okay, now that we know that, we can explain why a patient has internuclear ophthalmoplegia. Look at this patient, clinical information, bilateral internuclear ophthalmoplegia. We see an infarction posteriorly in the upper pons. Look at the superior cerebellar peduncles. Let's correlate with our sagittal images. Well, it's probably not so clearly to see, but the infarction is located over here in the upper pons. We have no oculomotor nuclei over there. The third nerve nucleus is located in the upper midbrain over here, and the abducens nucleus is located in the lower pons over here. But they are connected through the medial longitudinal fasciculus, and that is damaged. The result is internuclear ophthalmoplegia. I always love it when radiology and the clinical symptoms come together. It's not always the case, but when it happens, it's beautiful. Okay, this is a patient with a ramus ad pontem infarction, an infarction caused by an occlusion of the perforating branches for the pons coming from the basilar artery. And this patient also had diffusion restriction in both cerebellar peduncles. Why is that? Well, that is because the pontine nuclei and the corticopontine tracts are damaged, causing bilateral Wallerian degeneration of the middle cerebellar peduncles. Let's move on to another case. This patient had acute diplopia. And what do we see? We are looking at the level of the lower pons, and we see a very small lesion located approximately in the region of the right abducens nucleus. This is a very small cavernoma. It does not look as if it has hemorrhaged, but nevertheless, it's located in the region of the abducens nucleus. So the clinician will need to look if the acute diplopia clinically fits a right-sided abducens palsy. If that is so, that can be the cause of the diplopia, despite the fact that no signs of hemorrhage are present in this patient. Okay, final case. Here we see on this FLAIR image an area of edema located, well, approximately it's located in the lower pons. Here we see the middle cerebellar peduncle, so it's located laterally in the tegmentum. Is this an arbitrary location? No. This location corresponds to the course of the trigeminal fibers in the brainstem. On T1 weighted images, we see some faint gadolinium enhancement. On T2 weighted images, we more clearly see the area of edema. This patient had, as expected, because this is approximately the place where the trigeminal fibers run in the brainstem towards the trigeminal nuclei, this patient had sensory disturbances on the right side of the face. But normal chewing muscles. This could be an area of demyelination due to multiple sclerosis, but no other white matter lesions were present. Very important in this patient is that the patient also had a cold sore, which led us to a presumed diagnosis of a herpes simplex rhombencephalitis. It exists. We typically think that a herpes simplex encephalitis is located in temporal lobe, and that is true in a majority of cases, but in some cases it can also cause a brainstem rhombencephalitis, which will then typically involve the course of the trigeminal fibers in the brainstem. Here we see the area of edema, and located in front of it, we see the cisternal segment of the trigeminal nerve. And this is then the brainstem part of the trigeminal nerve, which shows edema. How do you get a herpes simplex rhombencephalitis? Well, this has to do with the pathophysiology of herpes simplex infection in the brain. So it all starts with a primary infection of the oral mucosa, of the lips, of the eyes, or sometimes of the nose, which is then a latent or an occult infection. So these are possible areas of a primary infection with herpes simplex virus type 1, and then the virus is transmitted through the trigeminal nerve branches of the mandibular nerve, the ophthalmic branch, or either the maxillary nerve or the olfactory nerve towards the trigeminal ganglion. Well, not if it's transmitted by the olfactory nerve clearly, but if it's transmitted by trigeminal branches to the trigeminal ganglion, and from the trigeminal ganglion to the brainstem. Or to the olfactory nerve. Yeah, okay. So herpes simplex encephalitis is basically a reactivation from a latent viral infection inside the trigeminal ganglion or the olfactory bulb, which can then spread to the limbic system. But if the virus is latent in the trigeminal ganglion, it can also spread towards the brainstem and cause a brainstem rhombencephalitis. So this was the point of this entire slide, to help you understand how herpes simplex virus can cause rhombencephalitis. Okay, we're almost done. Let's now talk about the medulla oblongata. So these I've already shown you, I believe. So the medulla oblongata, the upper part and the lower part. So the upper part looks more like a small butterfly, if you use your imagination, or a pair of boots, while the lower medulla oblongata starts to look already a bit like the upper cervical cord, having a bit more of a rounded appearance. Let's repeat the structures of the medulla oblongata. So when it comes to white matter, we have the corticospinal tracts located anteriorly in the basis. We have the medial lemniscus located paramedially, and the spinothalamic tract located posterolaterally. We have also a gray matter nucleus and medulla oblongata, the inferior olivary nucleus, which is basically an output center to the cerebellum. So it relays information to the cerebellum. What does it do exactly? Well, let's explain it a bit later. Now, just trust me, it's an output center to the cerebellum, and it basically does a bit what the cerebral loop does, but for involuntary movements. So it's basically correcting involuntary movements or repetitive involuntary movements, check them for errors, and correcting these movements for errors. So what are involuntary movements? Like movements involved in speech, swallowing, eye movements, those kind of things. More about that later. When it comes to the cranial nerves, we have the motor nuclei of the hypoglossal nerve located completely medially or paramedially. We have the ambiguous nucleus for the innervation of the throat, pharynx, and larynx. And we have the dorsal motor vagal nucleus, which is responsible for the autonomic information of thoraco-abdominal viscera. And then we have sensory nuclei, the spinal trigeminal nucleus, omnipresent, the solitary tract nucleus, a very important autonomic sensory nucleus, and the inferior vestibular nucleus. And let's not forget the inferior cerebellar peduncles. Okay, let's analyze medulla oblongata anatomy in a bit more detail. This small protrusion over here is also called the pyramid, and it basically shows us where the corticospinal tract is located. Then we have another protrusion called the olive, which basically shows us where the inferior olivary nucleus can be found. The small groove between the pyramid and the olive is called the pre-olivary groove, and this groove over here is then of course called the post-olivary groove. And this impression in front is the anterior median fissure. When it comes to cranial nerves, We can, at the level of the medulla oblongata, see the glossopharyngeal and vagus nerve exiting the medulla oblongata and the post-olivary groove. So this is basically the bundle of the glossopharyngeal and vagus nerves, also containing cranial roots of the accessory nerve. So we see it exiting the post-olivary groove and coursing towards the pars nervosa of the jugular foramen. And the hypoglossal nerve, and these are the nuclei, but I won't discuss those in detail. And this is the hypoglossal nerve exiting at the level of the pre-olivary groove. And here we have the hypoglossal canal, where it basically enters or exits the cranial vault and runs towards the tongue muscles. So this is the hypoglossal nucleus and the course of the hypoglossal nucleus. Let's show you some pathology to illustrate anatomy. This was a patient with an acute brainstem hemorrhage. It was caused by a cavernoma, but that's not important now. On a follow-up MRI performed 2 years later, at the place of the previous hemorrhage, we see some tissue loss and hemosiderosis. But we also saw something else, and this was a new finding, was not present on an MRI performed in the acute phase. We see a small nodule in the medulla oblongata. Did the patient develop a tumor over there? Well, theoretically it's always possible, but no, wasn't in this case. What is it then? Well, it's basically the same as what this guy has. In this guy, we see 2 nodules on both sides of the medulla oblongata. Let's look at some magnified images. Flare T2 and T1 with gadolinium, we see no enhancement whatsoever. These nodules are located in the olives, and this is what we call a hypertrophic degeneration of the inferior olivary nucleus. What is that exactly? It's basically a form of Wallerian degeneration, but Wallerian degeneration mostly causes atrophy when it involves the inferior olivary nucleus. It basically causes hypertrophy of the cells located over there, where is a bit unclear, but it's just what happens. And if it is degeneration, it means that some of the fibers going to the inferior olivary nucleus have to be damaged for this to occur. This isn't exactly true. In about half of cases, we can't really find a structural cause, but in another half of cases, we can. So what pathways should be damaged to cause a hypertrophic degeneration of the inferior olivary nucleus? Well, it has to be a component of the so-called Guillain Mollaret triangle. What is that? It's a pathway responsible for the fine-tuning of involuntary movements, like those involved in speech, swallowing, and eye movements, as already said. And this pathway involves the red nucleus, located in the midbrain, and the inferior olivary nucleus, located in the medulla oblongata, which are connected by a white matter tract called the central tegmental tract. It is located in the tegmentum, centrally, so the central tegmental tract. How easy can that be? Then information from the inferior olivary nucleus is relayed to the dentate nucleus indirectly. Why? This information basically goes to the cerebellar cortex and then from the cerebellar cortex to the dentate nucleus. And the dentate nucleus relays this information back to the red nucleus through the superior cerebellar peduncle. And then we have a triangle, the triangle of Guillain Mollaret. Let's look at these structures on axial images. So we have the red nucleus, which is connected with the inferior olivary nucleus through the central tegmental tract. So this is all located on the same part of the brainstem. Then fibers leave the inferior olivary nucleus and go to the other side through the inferior cerebellar peduncle. So they enter the contralateral cerebellar hemisphere, they go to the cortex, and from the cortex back to the dentate nucleus. And then information is sent from the dentate nucleus through the superior cerebellar peduncle to the contralateral red nucleus. Now, how do you get a hypertrophic olivary degeneration or a hypertrophic degeneration of the inferior olivary nucleus? If you have an insult involving the red nucleus or the central tegmental tract, you will get self-evidently a hypertrophic degeneration of the ipsilateral inferior olivary nucleus. Here are some examples. This was a patient with a brainstem hemorrhage with chronic tissue loss in the upper pons tegmentum, which might involve the central tegmental tract, and on follow-up, this patient developed ipsilateral hypertrophic degeneration of the inferior olivary nucleus. Here's another example. This is a patient with a tumor in the midbrain. It's probably involving the red nucleus, and the patient had an ipsilateral hypertrophic degeneration, and also, which is often can also be seen, atrophy of the contralateral cerebellar hemisphere. And why is that? Well, this information is then relayed to the contralateral cerebellar hemisphere. So this is probably also a form of Wallerian degeneration. If you have a lesion in the dentate nucleus or in the superior cerebellar peduncle, you will get degeneration, hypertrophic degeneration of the contralateral inferior olivary nucleus. Here's an example. This was a patient with postoperative tissue loss in the right dentate nucleus with the development of a contralateral HOD. And in this patient, we see that the patient suffered an old hemorrhage in the right dentate nucleus, and this patient also had a contralateral HOD. Of course, you can have a bilateral HOD if, for instance, both parts of the central tegmental tract or both central tegmental tracts are damaged, as was the case in this patient, for instance. In this patient, no structural cause was found, and as said, in about 50% of patients with a hypertrophic degeneration of the inferior olivary nucleus, you won't find a structural anomaly along the Guillain Mollaret triangle. Clinical presentations can vary, but a typical textbook presentation would be with a palatal myoclonus, so involuntary movements of the soft palate. And this has probably something to do with the fact that the vagal nucleus is located, or the ambiguous nucleus is located in the vicinity of the inferior olivary nucleus. This is a patient with a cavernoma in the midbrain. We see extensive damage in the midbrain, also involving both superior cerebellar peduncles. And in the acute phase, we see nothing in the medulla oblongata, but a year later, the patient had developed a bilateral hypertrophic degeneration of the inferior olivary nucleus. And on further follow-up, we see that these signal abnormalities gradually decrease and become less pronounced, but we can always see a little bit of it. So it is something that can evolve and regress on follow-up images. The main differential would be with a glioma. So in this patient, I believe this was an incidental finding, but I'm not sure, we see a quite large nodule involving the right olive of the medulla oblongata. This was not a hypertrophic degeneration. This was considered too big. We had no explanation, no structural lesion along the Guillain Mollaret triangle, and there was gradual increase on follow-up examinations. So this was considered a glioma because a hypertrophic degeneration will gradually regress on follow-up studies. It will generally not increase. And in this patient, you see also signal abnormalities in the left olive this time, but not with a clear expansion, but rather with some atrophy. And this patient also had an old infarction in the right MCA territory with hypo in the left MCA territory, with also atrophy of the left cerebral peduncle. So this is Wallerian degeneration or corticospinal tract atrophy. Then, to conclude, this is a patient with a pica infarction. We can see it quite clearly involving the medial inferior part of the cerebellar hemisphere, but it also involves the posterolateral part of the medulla oblongata. And here we see another patient with a medulla oblongata infarction, and infarctions in this location of the medulla oblongata are typically associated with a specific vascular syndrome called Wallenberg syndrome. You probably heard of it, but what is it again? Well, Wallenberg syndrome is a combination of symptoms that are caused by an insult and the medulla oblongata, more specifically posterolaterally in the medulla oblongata. What are those symptoms? These patients have a contralateral loss of pain and temperature sensation in the body due to damage to the spinothalamic tract. They have ipsilateral loss of pain and temperature sensation in the face due to damage to the spinal trigeminal nucleus. They have ipsilateral bulbar muscle weakness, so causing dysarthria, dysphonia, dysphagia, and so on, due to damage to the motor nucleus, motor ambiguous nucleus, which is responsible for the motor innervation of the throat. And finally, the patients have vestibulocerebellar symptoms like hemiataxia or vertigo due to damage to the inferior cerebellar peduncle and the vestibular nuclei. And also, they often have an ipsilateral Horner syndrome because sympathetic tracts running in the medulla oblongata are also involved. Okay, key messages, and I'm keeping them short despite the fact that it was a very large presentation. So I tried to simplify the anatomy of the brainstem for you, and I hope I succeeded. We can divide the brainstem in three parts: the midbrain, the pons, and the medulla oblongata. And in these various parts, we find three layers. Well, mostly two layers, and in the midbrain three, namely the basis containing the motor pathways, the tegmentum containing the sensory pathways, and also cranial nerve nuclei, and in the midbrain, we have the tectum containing nuclei responsible for visual and auditory reflex processing. The cranial nerves, we talked about them in great detail, but if you have to remember one thing, it is that the oculomotor and trochlear nerve are located in the upper and lower midbrain respectively. They are located along the midline because they are motor nerves. And the pons, we find the nuclei for cranial nerves 5 through 8, and the remaining cranial nerves can be found in the medulla oblongata. Okay, that's all, folks. So I hope you found it interesting. It's very difficult to make a complicated and extensive topic like brainstem anatomy easy and short. I know I repeat myself a lot. It's always difficult. What am I going to say? What am I not going to say? What is useful? What is not useful? If you have any comments, questions, or feedback, please leave a message in the comments section. I hope you enjoyed it, and I believe I have a lot of cases I didn't use, so I'm probably going to do a follow-up showing you more cases of brainstem pathology on imaging, and I'm also working on something about cranial nerve anatomy and pathology. So thank you very much for watching. And yes, like and subscribe. My son told me I have to say that. Like and subscribe, people. Like and subscribe. Thank you very much. And if you don't, no hard feelings. I do not really care. But if you do, that's cool. Okay, I'm going to stop now. Thank you very much for watching. Bye.